Hi, it's Dorette Noorhasan here, and we are at the Modern Parenthood podcast. And today I'm delighted to have Dr. Andrew Sun, urologist, here to talk about male infertility. You've heard some of my previous episodes where we speak a lot about female infertility, but sometimes we forget there's another half to making a baby. We need sperm, and we need good sperm to make a healthy pregnancy. While I'm a gynecologist by training, I have a urologist, Dr. Andrew Sun, here to explain the male aspect of fertility. So first of all, Dr. Sun, welcome to the show.
Absolutely. Thank you so much for having me. This is fantastic.
Please tell us a little bit about yourself, a little bit about your training, because I would love for the listeners to hear how much diversity you bring to this podcast and how different you are from me in terms of the training. So tell us a little bit about you and your training.
Well, my name's Andrew Sun, and I'm a urologist. Urology is the medical specialty dealing with diseases of the urinary system, such as, kidney stones and these kinds of things. But also, we are the equivalent in many ways of gynecology for the men. So we deal with male sexual function and dysfunction. For myself, I grew up on the East Coast. I went to Harvard Medical School, did urology residency at the Cleveland Clinic, and then did a fellowship, which is a hyper specialization specifically in male infertility and sexual medicine at UCLA. And so my practice here in the Dallas-Fort Worth area entirely focuses on male sexual function, dysfunction, and male infertility. The infertility part of my practice is unique because it's one that, we work together with. I sort of often say it's one of the only specialties where you have to consider two patients simultaneously. And so it requires a lot of collaboration because for sure, it takes two to tango to be super, classic about it. And it's great to have this kind of partnership.
Yes, wonderful. And that was so important that you said you did a urology fellowship, but different from the general urologists that do prostatectomies and other aspects of the urinary tract. You went and subspecialized in male infertility and sexual function in the males. And this is why your knowledge is so important for this podcast. And so we're delighted to have you here.
Yeah, exactly. It's a very small field. There's only about 12 to 15 fellowships, which means 12 to 15 people per year get trained in this hyper specialized area. I have pretty much stopped doing any general urology. I don't see women in my practice. I don't do kidney stones. I don't do prostatectomies or kidney surgery or bladder stuff. I 100% focus on essentially the male genitalia. So that includes the sexual part, but also the infertility part of it.
And similar for me, as my listeners have heard in previous podcasts, I did an OBGYN residency, but I don't do general obstetrics or general gynecology. I went ahead and subspecialized in reproductive endocrinology and infertility, and I really just do female reproduction. But again, there's another half to this. There's the male aspect, and I'm so delighted you're here.
This podcast is meant to provide information on reproductive health. It does not establish a physician-patient relationship, and we would urge you to contact your treating provider regarding your care.
Well, we're going to kick off the show with a patient example, just kind of talking about a typical patient that's going to walk into your and my office. So let's say we have John. He's 35 years of age, and he's married to Jessica. She's 30 years of age, and they've been trying for about 5 years to get pregnant naturally. No success. And here they are in their early 30s and think they should be able to get pregnant naturally. And we all feel like that is the case. And so they come and see me, and I do the full testing on the female. But as part of the testing, I also get a semen analysis on John. And his semen analysis shows 2 days of abstinence. The volume of the sample is about 1.4 mLs. Concentration, which is count, or the number of sperm in the sample, was about 5 million per milliliter. His motility was about 28%. Motility describes how fast the sperm swims. And then his morphology was about 1%. And morphology is the shape of the sperm, and shape influences how well the sperm can fertilize the egg. And these are very abnormal results. And again, because I'm a gynecologist by training, I said, I'm going to send you to Dr. Sun and have him explain some of this to you, as well as have him do some detailed testing. So, Dr. Sun, tell me what happens when John walks into your office. What should he expect?
Yeah, I love this. I would have that guy. Luckily, I would have that semen analysis already ahead of me. And so even before meeting the patient, I would kind of be going through my head, like what I'm thinking is going on. And so then, I walk in and introduce myself and whatnot. And we luckily have a little bit of background on why they're here. And then I sort of start explaining the semen analysis, right? I want to start by like laying the picture of what a semen analysis really is, because it's a surrogate marker of like the male's fertility potential, at least when it comes to their ability to like naturally conceive, right? And I tell people like I really have only 3 kinds of patients. I have patients with normal semen analyses. I have patients with semen analysis of 0, no sperm, and I have patients that are somewhere in between. And, he's somewhere in between. Yes, it's quite abnormal, so it's on the lower end of that. But I start off by telling them, look, at least it's not 0 because it's already a way better situation. The hardest patients to counsel are the azospermic. Azospermic means that there are no sperm seen in the semen sample. So, we got some work to do to try to improve these numbers, but we're starting off with at least the knowledge that he is capable of producing sperm. Sometimes that's the hardest differentiator for me to have to figure out, because there are some men who are either genetically or for whatever reason essentially unable to make sperm. But here we have a guy with lower sperm counts. Now, the other thing important for listeners about semen analyses is that these numbers are all expressed primarily in concentrations. And when you look at a number as a concentration, each individual variable has like a cutoff, but it's really the sum total of everything that kind of matters, right? So I use a common example with my patients. If 40% motility is normal, but I have 10 million sperm, and the second patient has 20% motility, but 100 million sperm, the second patient has a lot more total motile sperm. And so that's really, it's the concentration, but you also have to multiply by the number of actual sperm there, which is why the volume matters. So his volume is normal, 1.5. It's right at the lower end of what we would call normal. But his concentration is quite low, just measured as a few million, or 10 million, something like that. And then the motility is, low, and then the morphology is low. So the very long, complicated scientific term for this is oligoasthenoteratozoospermia, which nobody has to remember. But basically it means everything is kind of poor. So then we sit back and ask ourselves why. A patient like this is, relatively speaking, unlikely to have a major genetic condition. Most of the genetic conditions that we know of, they cause azospermia, meaning 0 sperm. So probably there is some variable, whether it's about him or his health or his anatomy or something that's contributing to this. And so we start off with like a very, very broad, history going back to when they were in the womb. Were you premature? Were there any birth complications? How was development? Was puberty normal? Did you start getting your facial hair and your voice getting deeper and all this kind of stuff, same as the other boys? And most people have some sense that everything seems pretty normal, or there's something really, really jumps out at you, like, hey, when I was 12, I had a testicular torsion. That's where your testicle actually twists on itself, and that could be obviously a big factor. So we go through the history in identifying any kind of major causes, and then we look at their sort of current state, right? And if I had to sum up all of male infertility science into one statement, it's basically that a healthy body makes healthy sperm, and an unhealthy body makes unhealthy sperm, right? For the vast majority of patients who don't have an underlying genetic problem, the issues are mostly due to their overall health. And so some of this is very obvious when you meet the patient. If they're extremely obese, if they smoke a lot, if they drink a lot, if they have diabetes, if they have a variety of other health conditions, that's also going to be reflected in the sperm quality. And so sometimes those are the things that we would identify to start addressing. And then, there's 2 more things. One is a physical exam, and we'll kind of go through these more in detail. And then the third is to get some lab testing. Well, all humans have the same sort of hormones, both testosterone, estradiol or estrogen, FSH and LH. We can explain these more in detail, but we basically want to check all of their hormones. So I tell the guys it's 3 things. It's like a history and assessment of your entire life. It's a physical exam, and it's hormone testing, in addition to the semen analysis that they've already come in with.
And you mentioned something something, the oligoasteroteratospermia, so oats. I hear that all the time from the male partners. So oats, oligo means low count. So oligo stands for low count. Asteno, meaning motility, so low motility. And terato is shape or morphology, so low morphology. So when they have oats on their semen analysis, that's one of the factors. But you're right, absolutely. I would rather have oats than not have anything, complete azoospermia. So this is great. So when they come in to see you, you get a history, as you mentioned, and then you do the physical exam. What are you looking for on the physical exam?
So, it's a variety of things. One, you could argue that just generally looking at the guy is a form of physical exam. Are they morbidly obese? Are they very thin? There are some very exotic genetic conditions that can be associated with certain appearances in terms of like the size of your limbs and like these kinds of things. But mostly it's like take a look at the guy and then take a look at his genitalia. And when I'm doing that, I'm looking for roughly an estimate of the size of the testicle. Is it relatively what I would expect for his body size? How does the testicle size compare to the size of the penis? What's the consistency of it? And this is subjective. It comes from the experience of, having felt many thousands of testicles. A testicle should feel like fairly plump or firm, however you want to call it. But if it's, for lack of a better term, kind of soft and squishy, that's like maybe not a good sign. There's a portion of the testicle, it's not a portion of the testicle, there's an organ behind the testicle called the epididymis, which is a complicated word. It looks like a mullet and it's sitting on the backside of your testicle. The purpose of the epididymis is to mature the sperm. So the sperm get created in the testicle, they swim in this very long convoluted duct into the epididymis, they mature in the epididymis, and then they go up the vas deferens. The vas deferens is the tunnel that connects, or the highway that connects the testicle to the prostate, which is the ejaculatory duct. Maybe I'll just step back and do a quick anatomy lesson. So you have two testicles. They hang in the scrotum. The testicles from, conception actually start up in the middle of the body, kind of close to the kidneys. The kidneys and the testicles, they form together. And then the kidneys kind of go up until they find their final location in the middle of the back. And the testicles go down, hopefully ending up in the scrotum. Now, sometimes they don't end up all the way in the scrotum, and that's called an undescended testicle, which if found at birth can be fixed. But, even just in the last 2 weeks, I've had 2 patients that have had undescended testicles that were never fixed from birth, and now they're like 35, but that has a serious impact on their fertility potential. So the testicles, the purpose of the testicles, they only do 2 things. They make sperm and they make testosterone. That's pretty much it. It's very simple if you just break it down. They do 2 things, sperm and testosterone. The epididymis that we were mentioning earlier sits on the backside of the testicle, and it's where the sperm mature. The epididymis does not make testosterone. And then the sperm swim through the vas deferens. If you ever heard of a vasectomy, that is cutting the vas deferens to basically block the flow of the sperm. And then they enter the prostate. The prostate is an organ that sits in front of the bladder. Prostate comes from the Greek word for guardian, and it's essentially a guardian in front of the bladder. The prostate, we kind of joke, it has 2 functions as well. Number 1 is that it makes semen. Semen is the fluid. Sperm are the little swimming guys, so they're different. So the prostate does 2 things. It makes semen, and it causes problems. But that's pretty much all it does. It gets in the way, it gets bigger as you get older, it's harder to pee, all of these things. And so the mixture of the semen and the sperm are what produces the ejaculate, which is what you need. There's a third thing called the seminal vesicles that also produce the semen that's on the backside of the prostate. But for all intents and purposes, we can just say there are the swimmers from the testicles and then the fluid from the prostate. They mix together, they get expelled, that's the ejaculate. And so we're looking for all of those things. Can I feel the vas deferens? There is a congenital abnormality associated with cystic fibrosis in which you actually don't have a vas deferens. Well, if you don't have a vas deferens, how can you get the sperm from the testicle to the ejaculatory system? You can't, right? So you feel the testicles, you feel the epididymis, you feel the vas, you look at everything together. And there's one more thing I'll mention, which is the testicles hang in the scrotum by we call it the cord. It's basically like a bunch of blood vessels and stuff that kind of feed the testicle. very commonly, in about 15% of men, the veins in that cord can be dilated and basically be a little bit beefier or thicker. In the textbooks, they call it a bag of worms, because that's kind of how it looks and how it feels. That's called a varicocele, very similar to varicose veins in the legs. And that collection of veins basically can have a negative impact on sperm. So we're also looking for that.
You touch on so many important things, and for our listeners, I will tell you. So, as females, when we were in our mother's uterus, our reproductive system developed as well, just as Dr. Sun explained. For the males, their reproductive system developed. Now, for us, our ovaries stay inside our body. So to reach our ovaries, we have to go in the belly to see a woman's ovaries. Our ovaries stay inside the body because the ovaries can tolerate high temperature, which is body temperature of 98.6 degrees Fahrenheit. For men, their testicles descend outside the body into the scrotum, where they need a cooler environment for spermatogenesis, essentially for the production of sperm. Once the sperm is produced, Dr. Sun, tell us, how long does it take to go from the production of sperm to that sperm actually being ejaculated into the external world where it can be produced? How long is that process?
It's roughly 2.5 months. I believe the number is 68 to 72 days for full maturation. There's a bunch of cell levels that the sperm have to go through, from like progenitor sperm cells to late progenitor sperm cells to, getting a tail and a head and all these kinds of things. And so there's like lots of little steps to make these guys, swimming. And so it takes about 2.5 months, which means anytime we intervene on anything in a guy, medications, lifestyle habit changes, things like this, we generally, set the next semen analysis to be at minimum 3 months later, because you kind of want to see the next full turnover of generation of sperm to see if you've made a difference or not. Sometimes things take longer, but that process, it's a slow one, right? It does take a while.
Just for clarification for our listeners, so progenitor sperm cells are what the sperm cells start off as. So they start off as progenitor cells, and they go through various levels of maturity to become the mature sperm cells. So, for example, in the testicle, when we do testicular sperm extraction, the sperm that we get is very immature. It has not gone through the entire maturation process. So just like Dr. Sun said, as the sperm travels through the epididymis and the vas deferens and to the outside world, in that 2.5 months, the sperm also develops maturity. So the sperm cell grows and gains maturity. And so the tail of the sperm improves, the ability of that sperm to swim improves during that 2.5 month process of maturation. Yeah, and I'm often asked by the males or the partners of my patients, well, I had COVID last week. Did that influence my semen parameters? Can you explain how that affects semen parameters and the timing in relation to that 2.5 months?
COVID specifically, very interestingly, actually, I believe they did some studies where they actually found some of the spike proteins in the semen. So there was like this big interesting thing. It was a few years ago now that people were very interested in that. Now, it's not something you pass along, like it's fine, but we can broaden it to the idea of like febrile illness, right? So meaning of fever. So as Dr. Noorhasan stated, the testicles want to be cold. Like the human body temperature, let's call it 97.5, right? The testicles want to be about 95. That's where they do the best for the sperm. That's why every guy on the planet knows you jump in like a cold pool, what happens to your scrotum? It sucks in, right? Why is it doing that? It's because your testicles are trying to get warm. And if it's a really hot day or you're in a sauna or a hot tub, your testicles like loosen up really easily because they're basically trying to get cool. But the problem is that if you're in a 105-degree sauna or a bathtub or a hot tub, they can't get cool enough. And so hot tub use, sauna use, excessive heat exposure, and that can actually happen even from seemingly mundane things like Truck drivers, we see a lot of this because they're literally sitting all day, and if they have larger thighs, you're basically cooking the sperm between your thighs like all day long, and that's also a source of excessive heat. Excessive heat is not good for the sperm, and they basically don't like it. And so wherever that comes from, it's bad. Now, a fever is essentially excessive heat in the entire body, right? Your body temperature rises. That's why you measure yourself 101, 102, 103. Well, that means your testicles are also being exposed to that temperature shock. So we can sometimes see pretty dramatic declines in semen parameters right after a febrile, meaning an illness with a fever, right? Like I said in the beginning, the sperm are a reflection of the health of the body, and that can be long-term for obesity and things like that. It can also be short-term. So if a patient comes in for a semen analysis and they're like, yeah, I just recovered from a fever, it was pretty rough, I might tell them that, why don't we just hold off a little bit? Because even if we get something today, it's going to be bad. And we're probably going to say, let's wait a few months so that you can kind of fully recover this to see what the real quote unquote baseline is. So it can take a few months. So it's the same kind of idea, which is you have to kind of be in your healthy state to get the good reflection of your healthy sperm.
And so the gentleman comes in, John, in this example, and he sees you take a thorough history, you've done a physical exam. What blood testing do you order in terms of hormones, in terms of genetic testing? And then when do you consider ordering a DNA fragmentation test? When do you consider ordering a scrotal ultrasound? Can you walk us through your thought process in terms of the evaluation?
Absolutely. So every guy pretty much is going to get the same starting hormone. So let's take it back one step. So the way that the human body works, and it's luckily much easier in men. I wasn't smart enough to understand the women's cycles. There's all sorts of rising and falling hormones. In men, it's very easy. It's basically you have a brain and you have testicles. And so the brain tells the testicles to do their job. And the testicles only have two jobs, right? They make sperm and they make testosterone. So there's one signal from this brain to make testosterone. That's called luteinizing hormone, or LH. That goes to the Leydig cells in the testicle. So L goes to L, and then it makes testosterone. The brain also makes a signal called follicle stimulating hormone, FSH, that goes to the Sertoli cells that makes sperm. So S goes to S goes to S. FSH to Sertoli cells to sperm. And that's it. That's pretty much plain and simple. So I need to know what the levels are of LH and FSH and the end products, which is the sperm, which we got from the semen analysis, and the testosterone. Testosterone also gets converted into estrogen. Every guy does this. Every guy needs estrogen, but the sperm kind of like testosterone more than estrogen. So I also want to know what the estrogen is. Then you may want to just kind of get the general hormones or general lab values. They may already have this from their primary care doctor, but their blood counts and their kidney function, and not that I'm necessarily a primary care doctor managing their cholesterol and diabetes, but if they don't have a primary care doctor, which is often the case because a lot of younger men are very bad about staying with their primary care doctor. Sometimes they haven't seen somebody in a while, but I can tell through their sperm that something about them is unhealthy. So I'll take the chance and say, hey, why don't we check your hemoglobin A1C, which is a diabetes measure, and your cholesterol, because you haven't been to the doctor since you've been to the pediatrician, and clearly the sperm is telling us that maybe you're not so healthy. And so from a sort of side standpoint, as the man's primary care doctor, much in the way that gynecologists oftentimes serve as women's primary care doctor, I also will check some of those things. There are, of course, secondary and more exotic kind of tests that we can order, but that's kind of how we start for most people.
Yeah, so the hemoglobin A1C I check as well in the females, particularly when I see abnormal numbers. And for our listeners, a hemoglobin A1C tells us about how well your sugars have been in control for the last 3 months. So sometimes I say, we'll just get a fasting sugar today, and patients get worried, I ate something bad last night. With a hemoglobin A1C, it actually tells us your long-term control over the last 3 months. And so it really does give us an accurate assessment of how well sugars are controlled. And Dr. Sun is right. When our sugars are not well controlled, when our cholesterol is poor, when our bodies are not healthy, all the cells in our body are not functioning the way they should work, including the eggs and sperm cells. So this is why checking for all these things are so important. Dr. Sun, you brought up the hormone testing, so FSH, LH, estradiol levels, and testosterone levels. Can you walk us through various scenarios of what these numbers look like, for example, in a male who has complete azoospermia, in a male who utilizes testosterone or steroid usage, in a male whose numbers are just a little bit off? Can you walk us through various scenarios of what these look like?
Yeah, the hormones give us a lot of information, right? The sperm tells us the end product. The hormones tell us or gives us a clue why the end product is the way that it is. I don't tell patients it's the brain. I tell them that you got brains and you got balls. It's just alliterative. I kind of like it. So everybody either has a brain problem or a ball problem, and the hormones are going to tell you which one it is, right? So let's say a normal person should have a testosterone, say, of 400 to 600, we'll just call it 500, a normal sperm count, and an FSH and LH level that's like 3, 4, something kind of in that range, right? The brain's telling the testicles to make sperm and testosterone. The testosterone's being made correctly. The sperm is being made correctly. Everything's kind of in that what we call homeostatic equilibrium. So it's nice and even. Now, if a patient has a bad semen analysis, there's two situations. We'll start with the more commonly fixable one, which is a brain problem. So if the FSH and the LH are low, like 1 or 0.8 or 1.2, then that means that the brain's signal to the testicles is not that strong. The testicles then may not respond as well and not make as much testosterone or sperm, but if it's a quiet brain, that's usually a result of lifestyle problems, right? Sleep and stress and, obesity and like not exercising and all these kinds of things. What this situation is telling you is that the guy's testicles are okay. They're just not, churning out at maximum potential, and the brain's kind of quiet. Other things that cause this, there are certain more exotic diagnoses like certain types of pituitary tumors or, opioid use and things like that. Those guys you can fix by turning on their brain. So if the brain is low, you can turn it up with different medications. The opposite is if the brain hormones are really high and the testosterone is low and the sperm is low. If the brain hormones are high, like 9, 10, 15, 20, 30, 40, 50. That's telling you that the brain is screaming at the testicles, hey guys, like do more work, make more T, make more sperm, but their T is low, less than 300 is low, so let's call it 200, and their sperm is poor. That's a ball problem, right? Because the brain is clearly working really well. It's screaming at the testicles, but their factory, the testicles, the balls, they're not responding adequately enough. That's a harder problem to fix because some ball problems you can fix, like a varicocele, the big vein dilation thing I mentioned before, and some ball problems are not easy to fix if it's more of an ingrained genetic, type of production issue, undescended testicles, things like that. Although it's not a perfect correlation, generally speaking, the higher the FSH, the worse the situation is, right? And that makes intuitive sense. It's like, how strong is the brain trying to scream at these testicles to do their thing? The more it's screaming, the more the testicles must not be great. And so when the FSH is like a little bit high, 6, 7, 8, 9, 10, like that's one thing. When it's like 25, 35, more than that, those patients are usually the ones that are azoospermic, right? Zero sperm in the ejaculate. One side piece of that, so estrogen is also important. We measure estradiol. Estradiol is made from testosterone by an enzyme called aromatase. Aromatase is present in fat, meaning the more fat you have, the more aromatase you have, the more of your testosterone you convert into estrogen. And every guy in the audience is going to be like, estrogen, I don't want any estrogen. You need some estrogen, right? Estrogen is important for bones and like all this stuff. But sperm like testosterone. And so sometimes patients, especially the larger ones, they're converting too much of their testosterone to estrogen. And so their testosterone level is like low. And so we can also intervene on that by blocking that conversion to get them less estrogen and more testosterone to help their testicles. Now, if you're thinking, oh, more testosterone, okay, well, how about I just take testosterone? That's like the worst thing you can do for fertility, right? So there's a very important nuance, which is that sperm require testosterone in the testicle to grow. When you take testosterone, you're getting it from the outside, let's say by an injection, right? And your blood level of testosterone can be whatever you want, through the roof. You can be a bodybuilder. But when your blood level of testosterone is that high, your brain says, wow, that is a lot of testosterone. I don't need to make any more testosterone. Why would I bother doing that? And so the FSH and LH levels go down, 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 and go to zero, which means that inside your testicles, you have no testosterone, even though in your bloodstream, you have a lot. Which means what? Which means no sperm production. And so when I see a guy who comes in and he's like, yeah, man, I'm not making sperm. And I can kind of tell, like, you know, he's looking pretty jacked. Like he clearly works out. I'm like, okay, I see what might be happening here. I check his testosterone level, it's 900. And I check his FSH and LH level and there's zero, right? There's only one possibility in the world that can create a testosterone level of 900 and an FSH and LH level of zero. And that's when you're taking testosterone. Because if it's with your own testosterone, you have to have an LH level to make that testosterone. Where is that testosterone coming from? It's coming from the outside. And those patients, unfortunately, don't make sperm. Now, we can recover that, you know, we can do some stuff there, but that's another one of the more common things now, especially as more and more guys take testosterone at younger and younger ages. But unfortunately, a lot of them aren't really warned that, oh, by the way, this is going to make you infertile. And so, you know, there are ways we can kind of work around that. Those, I would say, would be the big three scenarios, right? Testosterone patient, a low brain or a brain problem, and a ball problem. And that starts to get us to, you know, an idea of which one of these areas to intervene on.
You bring up something so important, and that's testosterone replacement therapy. There's so many T clinics going up now, and I drive past them all the time, and I get it. Testosterone, it makes you feel very good. It increases your muscle mass, increases libido, but it's not great if you plan on having children. And a lot of times men feel like, oh, if I can take some extra testosterone, I'll feel more manly and maybe I might be able to get my partner pregnant. But it actually works against that. And it's so important. And I'm glad you're here explaining this to our listeners, why testosterone replacement therapy is not good for male fertility, especially now that we're seeing more and more of these T clinics going up.
Yes, you know, and I'm a huge testosterone advocate. I prescribe many hundreds of thousands of testosterone prescriptions. I think it's miraculous stuff, especially in the treatment of metabolic syndrome, obesity, diabetes. All these things can be improved. But as you said, it's not for fertility. Now, there are medications we can give that will raise the body's internal production of your own testosterone, which is actually good for fertility. And so most guys come in who want testosterone, they ask to boost or, you know, their testosterone. And I'm like, you can boost it, but what you're thinking of is replacing it. Replacement is bad for fertility. Boosting it is good. You can boost it by sleeping better. You can boost it by losing weight. You can boost it by lifting weights. You can boost it by being healthy. You can boost it with certain medications that trick this brain ball sort of, you know, system into working harder. But you can't take it from the outside, because as soon as you take it from the outside, your brain says, I don't need to make any more, and you shut your factory down. And the longer you shut the factory down and the more completely you shut the factory down, the more difficult it can be to turn that factory back on. I mean, I like this is my analogies. Hey, you know, you got this factory, right? It doesn't produce like the widget as good, and I can give you some medications to like tune it up a little bit, and it can work a little bit better, and that'll help. Or I can outsource the production to another country, and you've basically turned the lights off and shut down the factory for 10 years. Do you think that if you come back in 10 years and turn the lights back on, that it's going to be better than it was before or worse? You know, like, this is a long-term commitment to take testosterone therapy, and it's sometimes hard to get off of it the longer you're on it and the more aggressive you are with it. You know, just as a word, there are different forms of testosterone therapy. No form of testosterone therapy is fertility friendly. There are some versions that are slightly less fertility unfriendly, but you should not think of it that way. You should think of testosterone replacement therapy as bad for your reproductive abilities. Also, your testicles shrink, so that should tell you what's happening right there, you know?
Another test I see often ordered for or male with abnormal semen parameters, and this is mostly for the men with azoospermia, so not having any sperm in their sample when we do a semen analysis, is I see a fructose test. Can you tell our listeners what is the purpose of this fructose test, and how does that work in terms of the anatomy, in terms of helping you figure out which part of the male reproduction may be off based on this fructose test?
Yeah, the fructose test is an interesting one. I admittedly don't use it as often myself, but what it's trying to get at is, well, you use the medical term, azoospermia, right? So again, no sperm in the ejaculate. There's two forms of azoospermia. We call it obstructive azoospermia and non-obstructive azoospermia, which is a very fancy medical way of saying, do you make sperm and it can't get out, i.e. it's blocked, or do you not make sperm, right? So if you don't make sperm, then your hormones usually have a more stronger indication that you don't make sperm. But that, presumably, most guys who don't make sperm, they still make prostatic fluid. They still have a vas deferens, and the prostatic fluid has a different sugar content. So fructose is a type of sugar, right? Like glucose, fructose, whatnot. So you're using the fructose to basically measure like what kind of fluid is coming out. Is it prostate fluid? Is it seminal fluid? Where is it coming from? Obstructive azoospermia, the most classic version of this, is a guy who's had a vasectomy, right? A guy who's had a vasectomy is still making sperm. And in fact, you're making sperm 24/7. It's not like the sperm that you had when you had the vasectomy are sitting in your testicles for the next 80 years. There's a constant production and death and rebirth cycle happening in there, but those sperm don't get out. You can also have, obstruction at the level of the prostate. You can have absence of the vas deferens or absence of the seminal vesicles. And essentially, it's trying to anatomically pinpoint which element of the male ejaculatory system may be disconnected or missing based on the sugar content of the fluid that comes out. We have a test called a vasogram. It's much less commonly performed than a hysterosalpingogram, or you can explain that better than I can. But a vasogram basically would be, we'd have to go into the penis and stick a little catheter right into the ejaculatory duct and shoot dye to see if it goes in. Very rarely do people do this because you can imagine that's not a very fun test. That would also be a way to look at this sort of anatomical obstruction. It's just that in men, random anatomical obstructions that don't have an obvious cause, like surgery or trauma, are very uncommon, much more uncommon than anatomical obstructions tend to be in women, I believe.
Now, for the men, when they come and see you and you've done the history, the physical exam, when do you order the ultrasounds for the testicles? I see sometimes the guys get it, sometimes they don't. And who are the right candidates for a testicular ultrasound?
Yeah, I think if you had to be wide net about it, you can always get an ultrasound. There's never a wrong reason to get an ultrasound. It's not a bad thing to get. It's nice to know. If the guy's hormones are normal and his testicles feel normal, or let's just even be more germane, if the guy's on testosterone therapy, what's an ultrasound really going to tell me? I kind of know what's going on here. I tend to reserve ultrasounds for people that their exam is off, If it feels like their testicles are reasonably normal size and I can feel the epididymis and I can feel the vas and I don't feel any cysts or things like that, we could still get an ultrasound. It would just seem to me like an unnecessary test. But again, you can still get it. But if a patient has a varicocele, arguably that's actually a clinical diagnosis, but it's nice to get an ultrasound just to see. If you have undescended testicles, if you can't feel a testicle, if you feel anything wrong with one of the testicles, our hands, our trained testicle feeling hands are pretty good, but an ultrasound's obviously better. So anytime something is wildly strange, like massive size difference between the two testicles, or you just feel something that's kind of strange, that's when I'll order a testicle ultrasound. Sometimes patients that have had history of torsion, which again is a twisting that happens usually on one side, that testicle is usually to some degree permanently affected. And so sometimes I like to get the ultrasound there. The ultrasound does give us a nice, very official sort of size measurement of the testicle, and size can be used as a correlation or a surrogate marker for different things when you're looking at obstructive versus non-obstructive, different conditions and things like that. So I tend to use it when I think there's a good reason to, but arguably, like, it's not a bad idea to just get one just to exclude any kind of anatomical thing in case you didn't feel it.
Tell us a little bit about anti-sperm antibodies. Is that something that we test for today? What is it, and do we test for it, and how do we get around anti-sperm antibodies?
The sperm and the bloodstream are generally considered like two separate domains inside the body, meaning immunologically, they're separate from each other. The white blood cells in your body that fight infection, they don't usually see the sperm. The sperm don't usually come into contact with the rest of the body. When that is violated, say with trauma, possibly with vasectomy, because that's a form of trauma, surgery, things like that, then suddenly the body's immune system like recognizes the sperm, this thing that it hasn't seen your entire life. And anytime the body sees a new thing, it recognizes it as a foreign substance, and so it creates antibodies to attack it. And so the concern with that is that if your body is attacking your own sperm, then, for lack of a better term, the sperm come out kind of clumpy, right? Goopy, clumpy. They got all these like antibodies all over them, and they may not function as well. The thing is that in like that can decrease the ability for spontaneous conception, because if the sperm are all coming out clumpy with all these antibodies on them, the question is can they swim as well? Can they get through the cervical mucus? Can they pierce the egg shell even if they make it all the way there? And so, certainly that is a factor. Now, you can take medications. It just doesn't, like, anti-inflammatories, steroids, immune suppressive medications. They just don't really work like super, super well. The good thing is that with modern assisted reproductive technologies, i.e., what you guys do, you can essentially wash away the antibodies. And so the easy button for anti-sperm antibodies is, let's just get the sperm sample, let's wash away the antibodies, and now the sperm is happy. And then you can, if there's enough sperm, you can do intrauterine insemination, or, as far as I'm concerned, I just leave it to you. You decide what to do with them. But it's luckily it's not that big of a deal because we have the technology,
Yeah, and for our listeners, in our previous episodes, we talked about IUI, intrauterine insemination, and then IVF with ICSI, intracytoplasmic sperm injection. And so Dr. Sun is right. When there's that clumping from the anti-sperm antibodies, the IUI, there is a washing process. And when the men gives us the sperm sample, before we can put the sperm back into the uterus, there's a series of washings that we do, and we concentrate down the sperm into a small sample for the insemination. But that washing ingredients that we put the sperm through gets rid of the clumping and the antibodies for IUI. And the same thing for IVF. We also prep the sperm, and through various gradients and washings, we can get the sperm just the sperm alone without all that clumping or the clumping parts of the that's associated with anti-sperm antibodies. And then with IVF, we do ICSI, intracytoplasmic sperm injection, where we're literally picking up a single sperm and injecting it into the egg to create the embryo. So definitely getting around the anti-sperm antibodies. Well, Dr. Sun, can you tell us, we've talked a lot about lifestyle changes and how healthy you are and how that influences how healthy your cells are, including your sperm cells. Can you tell us, give our listeners some examples of things they can do to improve their lifestyle in terms of eating, exercise, too much exercise, no exercise, therapies, treatments? We talked about saunas earlier on. Can you give us an example or give us some general lifestyle factors or lifestyle ways to live by for men who want to have good sperm?
For sure. And so, I like going back to the very beginning, just keep in the top of the mind, right? Healthy body, healthy sperm. As a men's health doctor, I sometimes tell people, like, if you wanted to give me the least amount of data and let me make a pretty dang good prediction about the overall health of a guy, give me his testosterone level. I mean, that would be the least amount, or his testosterone level and his sperm count. And if I have those two things, I could probably tell you in broad strokes if this guy, like, what he looks like, maybe how healthy he is, because ultimately these are very, very germane reflections of the health of the body. And so when thinking about making sperm better, if you make the body healthier, you make the sperm better. And so if you're obese, losing weight is a huge help. It not only raises your testosterone, it also directly improves your testicular function. as soon as I start talking to the guys about healthy lifestyle stuff, it's always like, so can I? And I'm always like, before you say it, ask yourself the question: is what you're about to ask me, does it sound healthy? If it's not, then don't do it. Like, because how many drinks can I have? And I'm like, well, ideally zero, but like, look, if you gotta live, have a drink or two. But especially with alcohol, we tell them like, I would rather somebody not drink at all. I would rather you have one drink 7 days in a row than 7 drinks on one day, because essentially, and it's not exactly like this, but you can close enough. Like, if you drink a lot, your sperm get drunk and they can't swim well and they get messed up, right? Tobacco smoke is extremely bad for the sperm. There's a lot of DNA damage that happens, and the DNA gets hit, and then it's not healthy anymore. Exercise is always healthy, specifically weightlifting, and partially because weightlifting does improve testosterone levels as well. But if you can do cardio, any exercise is better than completely being sedentary. The one thing that I enjoy myself that I think is healthy, but it's not healthy for the sperm, is the whole sauna, hot tub kind of excess heat thing. Does that mean you have to wear an ice pack on your testicles 24/7 and do ice baths? No. But they actually make like scrotal cooling underwear that's like a little ice pack that fits in a slot in these underwear. But I do tell my guys, like, maybe err on the side of looser underwear. If you're sitting down for long periods of time, maybe it sounds, weird, but like open your legs and like let them air out a little bit. Just don't let them bake in there. Don't keep a laptop right on your lap and like have all the heat from the laptop radiating into your testicles. As I mentioned, laptops, I should say, I get a lot of questions about like 5G and Wi-Fi stuff. And the short answer is like, nobody has any data to prove that. But like, sure, maybe don't keep your phone like right in front of your scrotum. Some of these things are sort of generalisms. I think overall, if you just kind of maintained a healthy lifestyle, like, that would be better. As far as diet, there's no specific diet, but one could argue that generally, like, say the Mediterranean diet or something rich in like whole real foods and low in processed foods and all things like this would be generally healthy. There's not like it's some kind of specific like special South Beach diet for fertility, but it's not a fad. It's just generally being healthy is good. Being thinner, walking around more, exercising more, and eating real foods and not like processed garbage, right? And sometimes, when it comes to the lifestyle stuff, I tell these guys, like, look, you are trying to embark on the most rewarding but also challenging like journey in your lifetime, which is being a parent. Don't you want to be the healthiest version of yourself so that you can be the best dad for your future children? And isn't this the best time to do that? Because if you can make these lifestyle changes now, then you'll have a more higher chance of having a baby, and you'll be better prepared to be the best dad that you can. Nobody wants to be not present for their kids. So sometimes, they're just like that. That's the motivation that they need, and hopefully it helps.
Wonderful. And so I like to end all my shows with debunking a few myths. So one of the myths is infertility is just a female issue. Dr. Sun, tell us about infertility in male, and is it just a female issue?
Couldn't be further from the truth, right? And in fact, the data is pretty roughly even. It's like a third of the time it's female factor only, a third of the time it's male factor only, and a third of the time it's both, which means 50 to 60% of the time the guy has something to do with it. So one, you should always investigate both partners. It's so tragic. It doesn't happen as much anymore, but I used to see a lot more like infertile couples, and the woman would have been on like a 3-year journey of like doing stuff, and the guy's like never checked his sperm, and I'm like, dude, what are you doing? But it's getting better now. There is more awareness of this as infertility kind of has become more commonplace and increasing. And there are now, direct to consumer sperm testing that you can do at home. I think no matter what, just for the guys, like, just check the sperm. There's really no harm to it. You can do it in an office, you can do it at home. It's something that guys are doing anyway, right? So just do it and get some knowledge so that you can be better prepared instead of like waiting and waiting and waiting, because look, it's not like emasculating or anything. It's very common because sperm is a reflection of overall health, that since the general population health of, well, we could just call it the Western world, is not great, that we're not surprised that sperm parameters have taken a hit. But knowledge is power, and the first step to doing something about it is knowing that there is an issue.
Yes, and a semen analysis is just a quick, easy one-time test just to get a general idea. I absolutely agree with you. Another myth I'd like to debunk is having babies at a much advanced age for men. So we've heard recently in the news that Al Pacino, Robert De Niro, they both had children in their late 70s and early 80s with their partners. Tell us the normal progression for male fertility.
Men are very fortunate in this aspect, right? Women are born with all of the eggs they'll ever have, and those eggs age. Men are constantly producing new sperm. Whether you're 18 or 80, you're still making new sperm. Now, your 80-year-old factory is not really going to be as productive as your 18-year-old factory. So there is some decline in semen quality and parameters. There is some data that shows higher rates of certain things like autism in fathers over the age of 40 and whatnot. It's not dramatic. It's not as of a sometimes, more dramatic cliff as it can be for women, but it's still there, and it can decline faster if you're not healthy, and it can be less of an impact, just like your testosterone levels, if you are really healthy. So while fathers certainly can theoretically father children, into later years, certainly it's not exactly the same being 80-year-old versus 18-year-old, even though the sperm is fresh. But like I said, that decline is slower, and the best thing you can do is just try to be the healthiest version of yourself.
Thank you, Dr. Sun, and thank you to our listeners. In our next episode, Dr. Sun will be visiting with me again, and we're going to talk about treatment options for male infertility. So stay tuned. Please like, follow, and subscribe so you can get all of our episodes.